Que somos parte del problema, hemos visto la magnitud y ahora el doctor Joao Neves pues, nos dará consejos prácticos de cómo podemos ser un poco más ecológicos.
Muy buenos días. En primer lugar, me gustaría disculpar de hablar en inglés, pero es muy más sencillo para mí para hacer esta ponencia. Aquí va. So my name is Joao Neves, and I'm a gastroenterology resident at the Algarve University Hospital Center in Portimão, Portugal. First of all, I would like to thank the organizing committee for the kind invitation to be here today to talk to you about some trucos de consejos para hacer un endoscopista más ecológico. Climate change is a reality affecting us all, but what some of us may not be aware of, and as ECO told us, healthcare is responsible for 4.4% of the world's carbon footprint. And if you look at it as a country, it would come out as fifth on top of the world's largest polluters. Endoscopy itself plays a major role on this, being the second highest waste generator per clinical procedure, and the third highest regulated medical waste generator in a hospital. This overwhelming data has alerted the endoscopy community, and several societies have recently released their position statements on sustainable endoscopy. But what can we actually do in our clinical practice in order to reduce this global threat? We can act before, during, or after the endoscopic procedures. But in order to do so, we should follow the 5R principles of sustainability: reduce, reuse, recycle, rethink, and research. And we should start off by reducing unnecessary endoscopic procedures. And this first tip is probably the most important and effective of all, because the greatest waste is a procedure that did not need to be done. And it is a fact that up to 56% of upper GI referrals and between 23 to 52% of colonoscopies are deemed inappropriate. But how can we mitigate this? Well, we can start by enhancing department vetting procedures, by dedicating time for triage. We can also implement regular educational activities to update emerging evidence for appropriate use of endoscopy, either by the means of simulations, meetings, or briefings. And lastly, but most importantly, we should follow guideline-supported referral pathways and look for sustainable alternatives. For example, the Baveno 7 consensus precludes the need of endoscopic assessment of varices in patients without a clinical significant portal hypertension. In gastric ulcers, we may also not need endoscopic surveillance if they look macroscopically benign, have a low risk score, and have negative biopsies. And nowadays, we can diagnose and monitor celiac disease without the need of endoscopy on a regular basis. And we should try to prioritize as much as we can less and non-invasive tests, such as the fecal calprotectin, which may be useful to avoid unnecessary endoscopic procedures in patients with a low likelihood of having IBD, and other strategies, although some of them not fully validated, which include the FIT, which can help us in the future to reduce by 80% the colonoscopy-based post-polypectomy surveillance, the cytosponge, which can be used for risk stratification in patients with Barrett's esophagus, and the capsule endoscopy and CT colonography for bowel cancer screening. We should also try to aim to reduce unnecessary paper documents, such as information leaflets and written informed consents, as paper comprises approximately 30% of all hospital waste. This can be replaced by interactive text message-based systems for appointment scheduling, for example, or the use of QR codes. Nevertheless, we must be aware of digital divide and save some double-sided printed copies on recycled paper for those patients who require or request paper formats. Another important measure, as Eiko told us before, is to reduce the unnecessary use of endoscopic accessories. This can be achieved by combining both upper and lower GI endoscopies whenever appropriate, as this will allow us to reduce the use of personal protective equipment and single-use consumables. It will also allow us to reduce water and energy consumption, and lastly, it will probably grant us the possibility of reusing some of these accessories between procedures in the same patient, for example, biopsy forceps or polypectomy snares. We should also be able to carefully assess and anticipate what will be required for each procedure. Due to the risk of cross-contamination and patient safety concerns, single-use accessories have gained a lot of terrain in the past 2 decades, and this also led to an increase of the net waste. Therefore, us as endoscopists should be able to train other endoscopists and the remaining staff in order to prevent excess and inadvertent use of accessories. In terms of the personal protective equipment, it has also largely increased in the past few years within endoscopy suits, mainly due to the pandemic, and nowadays it represents between 8 to 35% of overall endoscopic waste. Alternatives such as reusable gowns will allow us to reduce the carbon footprint in around 60%, and we also have the possibility to recycle some of these gowns, either by turning them into fuel via pyrolysis or by turning them into blocks of plastic for future use. Another important point is the use of histopathology. We should only perform biopsies whenever appropriate. And a recent study, and very interesting one, about the life cycle assessment of gastrointestinal biopsies has reached the conclusion that processing one biopsy jar with just one specimen emits 0.29 kilograms of CO2 equivalent, which is basically driving 1.13 kilometers on an average passenger vehicle. And we also know that we take a lot of biopsies in about 85% of endoscopic procedures, but clinical management is only influenced in a minority of this. So what can we actually do to lessen this burden? We should avoid routine confirmatory biopsies, for example, for H. pylori or celiac disease. We should try to adopt as much as we can the diagnose and leave and resect and discard strategies for diminutive polyps. But we all know that these are strategies that are difficult to implement, mainly due to the fear of missing high-grade dysplastic lesions. But I truly believe that with the advent of artificial intelligence, we may overcome some of these hard hurdles within a couple of years in the near future. Endoscopic waste, although it represents just a small part of the endoscopy carbon footprint, strategies to reduce, reuse, and recycle endoscopic waste are considered easy wins due to their low cost and easiness of implementation. And it is a fact that the majority of endoscopy staff does not know how to adequately categorize and dispose of waste. So therefore, it is thought that by training endoscopists on proper waste management to achieve a target percentage of regulated medical waste will have the most immediate impact on waste reduction. Also, most endoscopy staffs are still lacking recycling bins. And just by placing labeled ergonomic and accessible recycling bins within endoscopy suites, we'll be able to further mitigate this erroneous disposal of waste. Of course, correct waste handling and segregation depends on local policies. It's not the same from one hospital to another. But whenever performed correctly, it may lead to a significant reduction of the waste carbon footprint and a significant reduction of the economic burden of endoscopic procedures. Another key aspect regarding waste management is raising awareness of your staff. And I truly feel it is paramount to have a green endoscopy champion within every endoscopy unit, someone who is responsible for staff training, for leading interventions, and for performing regular audits and briefings. Coming down to energy consumption, it also plays a major role within the endoscopy carbon footprint. And for you to have an idea, just by replacing inefficient bulbs with LEDs and motion sensors, we can reduce greenhouse gas emissions and lighting costs in about 60% of cases. We should also try to adopt power down initiatives, which means turning off all electronic devices at the end of your working day, the computers we so-call that keep going on and turned on. And we should also try to implement these measures in our area of decontamination of endoscopes. And we should try to implement double basin wash machines and try to use both booths simultaneously whenever possible, as this will lead to a 25% decrease of energy use. Sterile water use is a rather controversial issue still nowadays, but because manufacturers and current guidelines still advocate its use for decontaminations, but there are strategies to reduce its use and especially to reduce the waste carbon footprint generated by single-use plastic bottles of sterile water. Some of them are reusing procedures leftover sterile water for bedside cleaning. We can also change our tap water and put filters on it, or just use the tap water for manual flushes through the scoping to the working channel. And we can also use final rinsed water as an alternative for automatic flushing systems. Lastly, it is also important to try to reduce as much post-endoscopy follow-up face-to-face appointments, but carefully select our patients. in order to avoid health inequalities. This will allow us to reduce some of the waiting times and also reduce greenhouse gas emissions, primarily associated with traveling. Coming down to rethink, I would like to stress out once again the need of a green endoscopy champion, someone who is responsible for educating and raising awareness of your staff, someone who keeps your medical personnel better informed about correct medical waste management. It has to be someone who is keen on reviewing existing practice in order to identify areas for future improvement. We should also rethink once again about the use of single-use accessories and try to involve as much as you can manufacturers and stakeholders and challenge them to disclose the life cycle of their single-use accessories. In terms of research, I think these are the four major topics that need urgent new data, and I encourage all endoscopy societies to encourage research on this, especially comparative studies on the life cycle assessment of both single-use versus reusable endoscopes and accessories as well. And it's urgent also to have more data about the performance and environmental impact of the non-endoscopic diagnostic alternatives and the endoscope decontamination. And it is truly important to clarify the incidence of clinical significant infections related to endoscopic procedures. To conclude, think before you scope. Reflect if the endoscopic procedure you're about to perform is truly necessary. Start off with low costs and easy measures to implement, the so-called easy wins. That include correct waste handling and segregation, implementation of recycling streams, reduction of printed documents, and establishment of power-down strategies to reduce energy consumption. And if at the beginning reducing the endoscopy carbon footprint may seem cumbersome without an immediate reward, remember that it is from small beginnings that steps of progress have been done. Thank you very much.